Recurrent ISR, what are my options? A recurrent ISR is defined as a second or subsequent event of instant stenosis after the successful treatment of an initial ISR lesion. The incidence has been increasing and it has become an aftermath of advanced coronary interventions. Initially it was about 10 to 13%, and initially it was described only for bare metal restenosis. But nowadays, most of the cases are seen in a patient with drug-eluting restenosis. The incidence may go up to 51% in patients who have a diffuse instant restenosis. But if we take all stents which are implanted in a given population, then the incidence is a more manageable, more conservative of 1.4%. The mechanism of recurrent ISR is multifactorial, and it's more common in patients who are old, females, obese, having CKD and diabetes, and stent fracture, stent recoil, stent under expansion, small vessel size, all of them contribute to the pathology of recurrent ISR. Intracoronary imaging provides an unique insights into the underlying etiology and mechanism of ISR, and in fact, it should be the first step in the management of recurrent ISR. There's a classification given by Waxman. We are all aware of the Mehran classification for instant restenosis in the olden days, but with the present era, it's a Waxman classification, and in that Waxman ISR classification, recurrent ISR belongs to the type 5, which has more than 2 layers of stent. Recurrent ISR may either be an incidental detection on angiography, or the patient may come to us with stable angina most of the time, and rarely acute MI, which is mostly non-STEMI MI. Some of the patients may present with NYH class 3 or 4 heart failure. Literature on ISR, recurrent ISR is sparse, and most of the studies are retrospective observational studies carrying a high risk of bias. And most of the treatment options which we discuss have been, for most of the time, the first ISR. There is a plethora of treatment modalities which are available for recurrent ISR, which includes conventional balloon angioplasty, repeat stenting, vascular brachytherapy, drug-eluting balloons, cutting balloon angioplasty, scoring balloons, stent ablation, coronary artery bypass grafting, of course, is the final court of appeal. But we do not have any guidelines to guide us, so there is a dilemma on what is the best option for treatment of recurrent instant restenosis. Added to this lack of literature, the patients have worse clinical and angiographic profiles, including high frequency of diabetes in almost 2/3 of the patients, chronic kidney disease, as we have discussed, 40%, bifurcation lesions in almost half of the patients, and moderate to severe calcified lesions in half of the patients. And added to that, most of the patients have undergone multiple prior interventions, and they have multiple metal layers of stents and narrower luminal diameters with high risk for additional recurrences. Conventional balloon angioplasty was one of the first strategies applied for treatment of recurrent ISR. It's technically easy and produces satisfactory acute results, and also it has low incidence of complications. But when we use high pressure dilatation for recurrent ISR, balloon slippage is a very common problem, and leading to the watermelon seeding phenomenon. This was one of the studies which has compared balloon angioplasty with repeat DES implantation in recurrent ISR, and there they found that binary restenosis rate was significantly higher in conventional balloon angioplasty of almost 65%, and incidence of 4-year MACE was significantly higher at 75% in patients who have undergone conventional balloon angioplasty. Repeat stenting is safe, effective, and it provides better acute and long-term angiographic results, but the rates of 1-year MACE and TLR are very high at 31% and 25% respectively. Repeat stenting introduces more layers of struts and worsens the milieu, which cause the restenosis in the first place, and multiple metal layers by themselves can result in luminal narrowing and stent thrombosis. So repeat DES stenting may not be an optimal option for the treatment of this challenging subgroup. In this study, they have found that re-DES implantation was no better than balloon angioplasty if the patient has 3 layers of stent or more layers of stent. Drug-coated balloon was the first real innovation for the treatment of both DES and BMS ISR. It is a semi-compliant balloon which is coated mostly with paclitaxel. Nowadays we do have some balloons with sirolimus and jotulimus coating. This paclitaxel is encapsulated in a lipophilic matrix which is released into the vessel wall after the balloon inflation. The drug-coated balloon has advantages over repeat DES because it does not have any metallic layer and it does not have any polymer, so that it does not induce any late thrombosis. So the drug-eluting balloon has the concept of leaving nothing behind. And it also has more homogeneous drug application to the vessel wall when compared to the stent, and it's an extensive contact area with the vessel wall. It shortens the endothelial healing time and reduces the duration of dual antiplatelet therapy. Of course, the disadvantages of drug-eluting balloon, some of them are there because of the high profile of the device, but the present generation drug-eluting balloon, they do not have such a high profile, we have a low profile balloon, and lower acute lumen gain when compared to repeat DES implantation. In 2006, the first human trial involving a drug-coated balloon demonstrated the superiority of such a device over POBA for the treatment of bare metal resistant restenosis, and the superiority was maintained for almost 5 years. The use of drug-coated balloon instead of repeat DES implantation is a particularly attractive option for patients who have multiple stent layers. In this comparative study between a repeat DES implantation and a drug-eluting balloon, they found that the drug-eluting balloon for more than 3 metal layer, for recurrent ISR who have more than 3 metal layers, was much more effective than reimplantation of a drug-eluting stent in a patient with recurrent ISR. We have something like cutting balloon and scoring balloons available. The lateral blades of the cutting balloon anchor the balloon within the target lesion, which prevents the balloon slippage. So as we have talked about the conventional POBA leading to watermelon seeding effect, a cutting balloon will prevent that effect. And it deeply inserts the neointimal tissue, favoring its subsequent extrusion. And it has shown promising results clearly which are superior to the conventional balloon angioplasty. And with a lower level of, lower rate of target TLVR, that is at 12.5% versus 40% for BA. A cutting balloon may also be used for preparation before implantation of a drug-eluting stent, a drug-coating balloon, or vascular brachytherapy. A scoring balloon is based on the same principle as a cutting balloon, but especially attractive because it's more flexible and deliverable. In this study, where scoring balloon, neointimal modification was done with a scoring balloon before drug-coating balloon therapy, they found that in patient, neointimal modification with scoring balloon before drug-coating balloon was superior to drug-coating balloon angioplasty alone. So, lesion preparation with either cutting balloon or scoring balloon is one of the important concepts for the treatment of recurrent ISR. Atheroablative therapy, either rotational atherectomy or excimer laser coronary angioplasty are the two most widely used techniques, especially in patients with recurrent ISR. They remove the obstructive restenotic tissue and allow larger final luminal gain and smaller residual neointima. And studies have suggested that the use of either laser or rotational atherectomy, followed by a conservative balloon post-dilatation, is superior to balloon angioplasty alone in patients with recurrent ISR. Although RA-bar is capable of producing metallic stent ablation, it should be used carefully because stent bar entrapment has been described, and then probably we can have a disaster in the cath lab. It's important to characterize the underlying mechanism and substrate of the recurrent ISR by means of either IVUS or OCT before using rotational atherectomy in a patient with recurrent ISR. Rotational atherectomy in this study was found that in patients with undilatable recurrent ISR lesions with either single or multiple stent layers, they had favorable procedural outcomes, but higher MACE rate driven TLR at 1 year. Now coming to excimer laser angioplasty, it produces a monochromatic light energy which generates heat and shock waves to disrupt the plaque. But vessel injuries such as perforation, dissection, and acute closure are very more common compared to rotational atherectomy, and so it should be used very judiciously, and that too only heavily calcified undilatable lesions in patients with diffuse instant restenosis. Intracoronary brachytherapy inhibits cell proliferation, and that's how it significantly reduces compared with conventional bundle angioplasty or other atheroablative techniques has been demonstrated in randomized control trials. It is associated with less inflammation, no additional layers of polymer, and no further encroachment or already narrowed lumen. Over the past year, the main indication for vascular brachytherapy has been recurrent DES ISR. And this is the study, I think, in lack of time, I will not go through the studies and all. Finally, the best way to DES ISR is to prevent it. And it can be prevented, the recurrent DES ISR is to prevent it by optimal stent deployment, utilization of imaging guiding implantation by IVUS or OCT, adequate coverage of the lesion, verifying stent expansion, apposition of the vessel wall, minimal use of BMS is, I think, no longer important nowadays. And I think I'll leave you with this treatment algorithm for recurrent ISR. And instant restenosis, the first step should be to identify the mechanism either by IVUS or OCT. And if the mechanism is DES under expansion, then the patient goes for high pressure balloon angioplasty or IVL may be considered. IVL is one of the upcoming modalities. Intravasal lithoplasty is one of the upcoming modalities of treatment for recurrent ISR. And if the patient has one layer ISR, I will leave it. And the second layer ISR, as you are told, either high pressure balloon, intracoronary imaging followed by high pressure balloon with a drug coating balloon is an effective strategy. And CABG should be considered in patients with high risk anatomy and who is a good surgical risk candidate.